The following content is provided under a Creative Commons license. Your support will help MIT OpenCourseware continue to offer high-quality educational resources for free. To make a donation or view additional materials from hundreds of MIT courses, visit MIT OpenCourseware at ocw.mit.edu.
My name is Dr. Hamish Fraser, and as Leo said, I'm the Director of Informatics and Telemedicine at Department of Health, and I'm also Assistant Professor at Harvard Medical School and the Brigham and Women's Hospital. So I'm actually been interested in this area for about a decade or so, surprisingly. I think when we started, people thought we were a little bit crazy. I think even Joia thought I was a little bit crazy. And but for some reason, the rest of the world seems to be believing that there's something interesting going on with information technology in development. And one of the pieces of that is the use of information systems to support the expansion of healthcare in very resource-poor environments in developing countries. So today what we wanted to start with is really a background about the challenges of healthcare in developing countries. And we're extremely fortunate that Joia Mukherjee, who's a colleague of mine and a friend, who's also the medical director of Partners in Health, has agreed to talk today about her experiences and about the challenges that Partners in Health and our colleagues around the world have faced. So Joia is an associate professor at the Brigham and Women's Hospital and Harvard Medical School, and she's also been working with Partners in Health for actually over a decade now, isn't it? Just over. Yeah, and I'll just tell you a little bit about Partners in Health itself, if you're not familiar with the organization. So it was founded in 1987 by Paul Farmer, Jim Kim, and Ophelia Dahl. And really it focuses on providing healthcare to the poorest and most vulnerable people in the developing world. And Partners in Health started working in the Central Plateau area of Haiti. And of course it's still very much one of the focus areas of ours, particularly over the last year with the earthquake and the cholera outbreak there. We focus very much on the roots of disease as well as the treatment of disease. So we focus on social justice, on providing better housing, access to clean water and food. And we also look at the interaction between elite institutions like MIT and Harvard and the kind of technology and medical education that these organizations can provide, and the challenges and the lived experience of people in very poor countries on a day-to-day basis. And we're particularly interested in this interaction between how we can actually learn different ways of providing healthcare, rather than scaling down what we have in the US or in other developed countries, but actually thinking about what is the experience and what are the real needs in those communities, and also what are the strengths of those communities. And Joia has also been working in this area, particularly medical education, and is, in addition to her work as a medical director, is the head of the Institute for Health and Social Justice at PIH. She's published or authored more than 50 journal articles, peer-reviewed journal articles. And I think really it's a great choice for this class, particularly because she's not tied particularly to technology. Joia really focuses on a whole range of different areas. She's board certified in pediatrics, internal medicine, and infectious diseases, and also has an MPH. So what we want to do here is not to focus this course on the technology, but to focus it on the problems and the real needs that people have, and then to look at how we can actually find creative ways of solving those. And one little secret about Joia, which not many people know, is that she was in fact doing medical engineering and I believe a little software development at some startup company. So, you know, she does have a little understanding about the kind of geeky stuff that we'll be focusing on here. Joia, thank you so much for coming.
Well, I myself was a recipient of some very high technology just this week. I had a electrical ablation of part of my conducting system in my heart. So if I seem a little short of breath, I'm just still on the mend from that. So probably one of the most high-tech outpatient procedures you can have. I was out of the hospital the same day after. It was fascinating. So actually, what I thought I would talk about, just to give a sense of, Hamish asked me to talk about our work, but what I wanted to do is focus on not only the work of delivering healthcare, but how we use the interface of academia to sort of promote our work and even promote social change. Because for us, it's not, yeah, sure. For us, it's definitely not only about, for us, it's not only about sort of providing healthcare to the people in front of us, but really changing how healthcare as a basic right is perceived. I think some of you know that the standard of care in resource-poor settings is to do very little. The standard of care in resource-poor settings focuses on prevention, not generally treatment, and is limited often by the GDP of the country. And as a result, the life expectancy in some of the world's poorest countries is under 40. And sort of our philosophy is that's just not appropriate. That we have, the idea of appropriate technology, as Hamish said, being a dumbed down version is not working to improve life expectancy for the poorest people in the world. So what we have sort of the inverse way of looking at it by saying, what are the needs? How do we address them? Doing the scholarship needed around addressing those needs, and then really trying to push the envelope for money, for resources, and for change. Because for partners in health, we really look at the medical context as sort of a thermometer for social inequality. And so rather than just try to bring the fever down, we want to deal with the root cause, which often is the social context. So I'm going to talk a little bit about sort of how we built up over time different chains of evidence, scholarly evidence, that is a fairly novel type of scholarship. I mean, I would say even 10 or so years ago when Hamish and I started at Partners in Health, the kind of work we do is not really considered scholarly research. But more and more people are realizing that in the implementation and in the application and in the description of the work we do, there's value in terms of teaching and learning. So that's what I'm going to talk about. This is one of my favorite slides. Does everyone know what this is? Oh, come on. What does it look like? What does it look like? You're going to have to talk to me because I don't believe in
nighttime around the world.
It's nighttime around the world. And it's interesting, right? So what does it show you?
It's not possible.
Yeah, it kind of does show you, who said that, not possible? Right, it kind of says, well, here in the Northeast, we have electricity, and we can do a lot of stuff. So this is a sort of map to me of low expectations, right? Now, interestingly, keep this in your head, okay? Here's another map. Isn't that, interestingly, the inverse of the electricity grid? So do you think that there's more AIDS in dark places because people don't have electricity? Maybe they just have more sex in the dark. I don't know, we could test that hypothesis. So what do you think this is about? I mean, this is kind of, to me, I love this. I mean, I love these kind of things superimposed. I like to do it together, but I haven't done that yet. But what do you think that's about? Yeah.
It's about level income, poverty, lack of education.
Yeah. So for in the beginning of the AIDS epidemic, there was this focus on prevention, right? And so we're saying, well, what about just bringing electricity? No, I'm just kidding. But so, whoops, sorry, I went all the way to the end. Now you're gonna see all that happen. So much for my geeky side. So, come on, look at that. You could say, well, just bring electricity would fix it. Would that fix it? Would that fix the AIDS epidemic? No? How did these places get electricity? Well, so that's what we're going to talk about. So, of course, I don't think electricity would fix the AIDS epidemic. But I do think that decreasing extreme poverty would minimize people's risk of epidemic diseases like AIDS and TB and malaria, right? Because we know that a lot of the risks are embedded in the social context. And in fact, most of what I teach is social medicine, which is really looking at the social context of disease. And so I always think this is a very interesting way to start the discussion, to say, what is it about the electrical grid, or the lack thereof, that really predisposes people? So this is kind of a timeline of the work of Partners in Health. And in the early years, we were just focused on delivering primary health care to a population in rural Haiti. In fact, a displaced population, a bunch of people who were displaced by a hydroelectric dam, kind of ran up this rocky hill, couldn't farm, couldn't do anything, and they were sick and they were dying. Now, the first thing we always do in a community is sit with the community and say, so what do you need? And so in this community, when we asked, so what do you need? What do you think they said? What do you think they said? Mercedes-Benz? No. What?
Food, water.
Food, water,
Shelter.
shelter. Two more things, probably. Three. Schools. Huh? Schools.
Healthcare.
Healthcare. Jobs. Okay. So these 6 things are those. I don't know how much you know about the public health paradigm, but how much of that is in like the public health paradigm? Almost none, right? Maybe water and sanitation. So you could do a needs assessment, which is often done in research settings, and you could say, well, these are the things people need. They need schools, they need healthcare, they need jobs, they need appropriate shelter, sanitation, and so what might you do? Well, we decided at Partners in Health to build a clinic and a school, and to employ local people, and a water system, and to employ local people to be engaged in the work of providing health care and the school and the water system. So does that sound kind of logical, or?
I think in the context of developed country, you have to have a more holistic approach. You cannot, like in Haiti, medicine is like vertical, and you have to, in the context of development, you have to see health with
Right.
development. You have
Right.
to see care with development.
Yeah.
And it's
So
all
in
embedded.
so one of the ways we address that is to say that education is critical development and jobs are critical development, and we can employ local people to do that. So I think you're right. What else do you think? I mean, is this sort of, let's say you're UNICEF or the WHO, and you go into a community and do a needs assessment. What might you plan? What are the sort of typical public health kind of programs to address the needs assessment?
I think you want to know what they have on the ground, the facilities they have on the ground,
Mhm.
strengthen the systems, not
Yeah.
necessarily building new ones.
Yeah.
And if they have a dysfunctional educational system, you could go around, walk around the factors that make it dysfunctional and try to provide some form of support systems for this.
Yeah.
And
I mean, I think that's a terrific approach. I think that's a terrific approach. I think we have to be intellectually honest when we do this kind of needs assessment to actually say, what is the real need? Unfortunately, that has not been the health-related view of a needs assessment with development. So where are you from?
Nigeria.
Okay, I thought you might be not. Perfect. I'm so glad you're from Nigeria. What happened when the WHO and UNICEF tried to do the polio eradication in Nigeria?
They had it was it suddenly it panned out to be a political war between the government officials and the donors from WHO and the UNICEF. And at the end of the day, it became kind of a vertical program, and some people argue that it worked, and the figures it worked, but back home you could feel that that bad blood between the government officials and the people from the WHO, that there was no really so much of communication.
Does everyone know this story? No? It's a great story. So UNICEF, WHO comes into Nigeria, and they say Nigeria is probably the main country in Africa that still has real polio, real endemic polio. And so we really want to focus polio eradication in Nigeria. Okay, because that's how we're going to eradicate global eradication of polio. So it seems like a good idea, right? So they brought big trucks with people, with the cold chain, with et cetera, and wanted to do these mass polio vaccinations. And in some places, in the poorest places in northern Nigeria, the communities refused. They refused. And you're looking puzzled, right? But why did they refuse? Because we're hearing there was a lot of bad blood. Maybe it worked. Maybe it was worked. So I'll tell you what the paper said, the initial report. So you're giving a better nuance thing. The initial report said the Muslim clerics don't believe in vaccination. It's a health belief problem. But what you're saying is different. It wasn't a health belief problem. What was it?
Lack of health promotion.
It was this whole idea of a vertical program. These people are community leaders. They're sitting in a poor community that has, open sewage, right? They have no quality of water. They have absolutely no health care. And some foreigners come in and want to give polio. Not really the highest thing on their agenda, right? So this idea of sort of really discussing with the community the needs and trying to address the needs, had that been done, I believe it would have been a much different, I mean, you tell me, you're Nigerian, but there wasn't a discussion with the community. Is this a priority? How do we embed this in something that really works? Right? I mean, do you think that was...
Yes, at the time they just felt that it was a place where you could just come and dump vaccines, not taking into consideration the stakeholders on the ground. So what happened was that over time there were rumors of the vaccine causing other comorbidities, and the vaccines causing things like infertility when you get older, and basically I knew that was just political propaganda from the people that really...
Who were mad about it.
Yes, they were really mad about it, so they had to come at it with every story they could come up with. So generally they didn't want to know what the people needed, and it ended up like that.
Go ahead. Yeah.
So do you regard smallpox vaccination as having similar failures?
I do. Is that controversial? Tell me what you think. Yeah, please do.
I think there are a critical part in the smallpox history where they turn out from institutional activities to community outreach. When
Absolutely.
They go
Yeah.
and find, do active screening with community workers.
Right.
And this was the U-turn that made the smallpox a success.
Right? And it's cool that we don't have smallpox. I mean, I'm an infectious disease doctor. Once in a blue moon, someone will throw a picture of a smallpox case up there to throw off somebody. It doesn't exist. It's awesome. But what was built with the eradication of smallpox? Almost nothing. And so I don't think the eradication of smallpox was a failure. It was a success in eradicating a disease. But the same children who would have died of smallpox die of measles today and die of malnutrition. So I think part of what I think your course organizers want you to come away with is we would like to capture complexity. We would like not to dumb down the delivery of healthcare and addressing the social context of healthcare to poor people. So try to raise your sights. I mean, you're lucky because a lot of you are not necessarily inculcated in the public health prevention only method. Some of you may be, and it's going to be a little jarring, right? Because we're talking about investing money. We're talking about bringing resources and technology to communities that really were sort of just dumped a vaccine, right? And vaccination is good. I myself have given thousands of polio vaccines in my life. Love it, love it. But not in the absence of treating HIV, tuberculosis, making sure women don't die in childbirth, finding a child who needs to be treated for malnutrition. So I'm going to kind of talk about taking each of those steps through a process of delivery and then scholarship and then sort of trying to change the paradigm. So when about the time Hamish and I started at Partners in Health, we were asked by a very small, poor community in the slums of Peru to do the same kind of work that we did in Haiti, which was to sit with the community and sort of say, what is it you need, and plan a community-based, like you said, sort of the strength of the community, we certainly believe has been a positive aspect of things like smallpox eradication, and say, what are the key problems in this community? Well, lo and behold, what became a real shock to us was one of the biggest problems faced by this very poor community was tuberculosis. And that struck us as very strange, because at the time, the tuberculosis program in Peru was rated by the WHO the best in the world. Okay, the best in the world. So we had all these community members that themselves were dying of tuberculosis while on treatment. So what was going on? I mean, you can read the slide. So what do you think was going on? These people were dying of tuberculosis while on treatment.
Resistance?
Yeah, they had resistance. So we said to the government, we think these people have resistant tuberculosis. We said that to the WHO. I mean, at the time, Partners in Health was tiny. I was the first physician Partners in Health ever hired, like, in 99. It was Paul Farmer was already a full professor. Jim Kim was still moonlighting at the Brigham to pay his salary, and I was like full-time. So we had like this tiny staff, right? 75, community health workers in Peru, about 200 in Haiti, and a tiny little clinic. And we said to the WHO, these people have drug resistance, and what do you think their response was? You're shaking your head. No, they don't. First of all, no, they don't. So we actually had to bring this sputum back to the United States, which, by the way, is against the law, without a permit, and bring it to the Massachusetts State Laboratory, again, trying to leverage technology, because even in Peru, they said, well, we don't have the technology to do TB culture. By the way, TB culture was invented in 1888. You know how much it costs to do a TB culture? $1.
So why couldn't you guys do it?
Huh?
Why couldn't you guys do it there?
They said they didn't have the facilities to do it, because nobody had ever put money into the health sector. It wasn't considered the sustainable route for a country like Peru to have a real TB lab, even though to Peru at the time, with only 5% of the population of South America, had 25% of the TB cases. So one of the highest burden countries in the world per capita with tuberculosis, no functioning TB lab because it's too expensive, too high tech, too demanding of human resources. So we brought it back to Mass State Lab, did the thing, thought, oh my God, these people have highly resistant TB. So we started to show this data to the government of Peru and to the WHO, and saying we could treat this. I mean, in the United States, we had a little outbreak of drug-resistant TB in the 90s, and it's a treatable disease. It's not that you have to die. And we were roundly criticized. And in fact, it changed Partners in Health a lot, because it vaulted us from this kind of tiny community-based, solidarity-based group to sort of being involved in these huge political policy debates around who should get treatment of what. Okay, so why do you think people didn't want to treat tuberculosis, drug-resistant tuberculosis? So we treated these patients. And so, what? Now, Peru kept saying, but we have the best TB program in the world. We have the best TB control program in the world. So why are those people getting drug-resistant TB? Why do you think you would, if you're a public health official, what might you say? Now, I have a degree in public health, so I'm allowed to slam public health, which I often do. Compliance. This is the best excuse. How many doctors are in the room? This is the best thing to do. If a patient doesn't do well, you say it's their fault, right? That's how you wash your hands of the responsibility for a bad outcome, right? So they said these are stupid poor people and they're not taking their medicines, and that's why they have MDR-TB. So we don't care about them. Now, first of all, it's it doesn't make sense, because here Peru is saying they have the best TB program in the world, and they're saying these people are taking their medicines. The reason Peru had the best TB program in the world is that everyone took their medicines. They would go find you, they would hunt you down. So we had the records that all of these people were in fact taking their medicines religiously, under penalty of imprisonment, right? So we knew they were taking their medicine. So then why? Did they have MDR-TB? Yeah, see? Therein lies the rub. Well, it turned out a couple,
Quality of the drugs?
Quality of the drugs is certainly a factor in a lot of places. It probably wasn't in Peru as much. So that could be, yeah, you don't have good quality drugs.
I think there's a really correlation between nutritional status.
Yeah, like, so this is the quote-unquote house that these patients were living in, often 10 to a one-room house. They're poor, they have bad nutrition, they have no real ventilation to speak of. I mean, I don't know. This doesn't even, but this is what the slums of Lima look like. And so let's say one person didn't take their medicines in this house, and they were spreading resistant tuberculosis to everyone in the house. So then we said, look, they all have drug-resistant TB, and here's their treatment card, and these people all took their TB, and still people didn't believe it. They didn't want to believe it because it made the situation more complex. So we actually had to do RFLP, restriction fragment length polymorphisms, which is a genetic test of the strain to show who had the same strain in the family, because people were saying, well, drug-resistant TB is not, it's not transmissible. It's like, so we had to, yeah, I know, it's stupid, huh? I used to just lose it. I can't go to TB meetings anymore because I get so angry at the TB guys still. Like, I hate them. So they said, well, it's not transmissible. So there's some weird technicality that, occasionally the kind of resistance that develops in a TB strain makes it less fit. But that's not even the norm. It's just like one small type of mutation. I mean, these people had 7 drug-resistant, 5, 10 drug-resistant, drugs to which their strains were resistant. So the primary here are all the people who had the same restriction length, fragment length polymorphism, RFLP. So probably this person, these 2 people in 90-91 maybe had developed resistant TB from not taking their meds or whatever. The actually good, best TB program in the world started in 1990. So it may have been people who were infected before, got poor quality drugs, or didn't have the adequate treatment. But then everyone else in the family had that same strain. So if we had not had access to kind of that technology, no one would have believed this. And so for us, we felt like it's good, it's like a good Samaritan thing to do to treat these people, but we also had to do the scholarship to show that in Peru, in a place where we knew that their compliance was excellent, if they were failing therapy, which the average length of time that our original 75 patients had been treated for tuberculosis was 14 months. Okay? We had some people who had been on treatment for TB for 5 years. Ineffective treatment, making them more and more resistant each time. So we showed that in a place where the TB program works, people are getting their medicines. If they are failing at month 3, they probably have drug-resistant TB, and you need to do something. So this was a way we really pushed the envelope to say, it's not okay just to kind of pick the cheapest intervention and apply that. So when we first started treating this disease, the treatment cost was $30,000 per patient for a cure. So what are you going to say about that? Yeah, where'd you get the money? Like, how can you? So we just said, look, we can find the money. And we had an amazing benefactor who really cared about poor people. And he said, yeah, okay, I'll pay for it. But more importantly, we used this research and other pieces of data showing that it was curable, showing that there was a global pandemic going on at the time. I mean, this is a little kid. This is a little kid for doctors in the room. This is classic POTS disease on an MRI. And this is a little kid after treatment. And we actually did another study just showing that in the first 16 kids that we treated, they all had been on treatment for a really long time because there was no way to move them to drug-resistant TB treatment. So, you know, this kid was paralyzed. Now he's fine. He's probably 14 or 15 now. I haven't seen him in years. But what we did is sort of make a documentation around the world of the prevalence of drug resistance to say this is a real public health threat. It is possible. So we first show the overall burden of disease. Then we show it's feasible. Then we try to develop protocols. And all of these things, again, you need that sort of feedback loop. Some is the electronic data, some is the laboratory technology, some is et cetera. And then what was interesting is once we showed the need, the prices of the drugs dropped. You know why? Why would the prices of the drugs drop after we showed the need? We actually, one of the ways we did it, we did this overall review of how much MDR there was in the world. We showed it was everywhere, and then we fought to get the second line drugs on the essential med list of the WHO.
What is MDR?
Drug-resistant TB. Sorry, multi-drug resistant TB. Yeah.
Economies of scale.
I was going to say, the manufacturers of the drugs know that they can sell a lot more now because it's going to be encouraged at lower prices.
That's right.
So the intake's going to be a lot higher.
So in other words, part of this advocacy was pushing the price down. And now you can cure somebody with a drug-resistant TB for about $1,700. The price is still quite high, probably too high, given the burden of disease around the world. We think there are somewhere in the neighborhood of 500,000 cases that need to be treated. But you know, certainly more than a tenfold drop in a span of just a couple of years by showing the need and the economies of scale. And what's interesting with drug-resistant TB is none of the drugs are even on patents. Right? So it wasn't even a patent issue, it was just a supply and demand issue. We showed the demand was there. And then, of course, this was tied with advocacy for more money for epidemic diseases, and the Global Fund to Fight AIDS, TB, and Malaria provides the majority of money to countries to treat drug-resistant TB today. So, again, just sort of talking about, so, you know, we had this kind of crazy idea that, wow, we won this fight. We were this tiny little, like, Don Quixote-sized organization taking on the WHO, and we won, actually. We won, saying this treatment should be available to people in resource-poor settings. Now, I don't think it was that big of a success because, in fact, this is a more complicated disease to treat than HIV, to be frank. And the drugs still haven't come down enough in price, and the accessibility of this treatment is not what I would like it to be around the world. But it gave us sort of the sense that maybe these questions are solvable if we do show the burden of disease, show the feasibility of this, develop protocols for it to be sort of scaled up, and then document that. And that advocacy can be connected with that kind of chain of scholarship. And so for me, what I'm talking about now a lot is a new kind of translational research, because we think of translational research as bench to bedside, or sometimes like bedside to adaptation in the US. But nobody really thinks of translational research as something that we know works, but we have to get it to the majority of the world. And there is a needed scholarship and understanding of how you develop systems to do this. So about the same time, about 98, a similar thing happened in Haiti, which is a lot of our own healthcare workers and people who lived in this little community of college. And actually was an MIT undergrad, I think, or Harvard undergrad. Sanjay's at MIT. An MIT undergrad, great guy, who's an AIDS doctor now, Sanjay Basu, who said, I'm going to try to get some drugs for you. We thought we have to treat these people. These are our people. These are our health workers. These are our friends. So we started treating them with highly active antiretroviral therapy, which, by the way, was one of the most miraculous things in medicine in the 20th century. So for people like me who started medical school in the peak of the AIDS epidemic, and then suddenly in '95 we stopped seeing people die. Suddenly in '95 you're invited to people's weddings and graduations instead of funerals. Totally changed everything. Now I myself had worked in Africa before coming to PIH, and I was in Uganda in '94 and '95, which was really, Uganda was the epicenter of the epidemic. And '94, '95, there was no treatment in the US or anywhere else in the world. So the best you could do anywhere was prevention. So about the same time, everybody's focused on prevention. They're looking at that map of the global AIDS epidemic, and they're saying, we've got to do prevention, prevention, prevention. And there was this little window that occurred where we started to see these successive treatments. So this, there are two people who've taught me more about HIV than anyone else, because I spent a lot of my life doing prevention. I spent 2 years working in rural Uganda doing prevention. I did tons of HIV prevention. I mean, I'm from an Indian family, so, just talking about sex is sort of not even really permitted. And then I would send my dad pictures, like with a box of 6,000 condoms marked USAID, saying, having a great time, Dad. But there were two people. This little girl, who's 9, who's the head of a family. These are her siblings who she is raising alone. Okay, this is a not uncommon scenario in sub-Saharan Africa, particularly at the height of the AIDS epidemic. Child-headed household, 9-year-old girl, okay? And this guy. You know who this guy is? The guy who snorted his father's ashes, right? So why, Keith Richards, he's a Rolling Stone guy, just wrote a really kind of crazy book that has supported all my hypothesis of talking about him all these years. So, does Keith Richards have HIV? No, he doesn't. So here's the contrast. Aging, totally promiscuous, drug-addicted, wacko, rock and roll star versus girl under 15 who's an orphan and the head of the household. Who statistically had more risk of having HIV? That little girl. So while everyone's telling us you've got to do prevention, we're like, this is not about behavior. Like, why is this little girl at risk for HIV? Because she's having so much fun? She's whoring around? I mean, why is that little girl at risk?
She's more vulnerable.
What makes her vulnerable? Vulnerable to what?
Vulnerable to social context in poor settings, probably it's an embedment of several social issues,
right,
for developing countries, like gender issues, like poverty,
right,
and
you guys, yeah, exactly. And you guys are lucky, because in this little class here, it's a pretty diverse group. But I used to talk about this 10 years ago, and I tell you, the Harvard students, the medical students, they did not get it at all. They really didn't get it. I think the ethos about this has really changed in 10 years. But it is, in fact, the social factor. So not to say that prevention doesn't work, but what we documented using work from Haiti, using work from other places, was that prevention is absolutely insufficient for dealing with this epidemic, because the only prevention we talk about is individual behavior change. And if you are a 9-year-old head of a household, your individual behavior is not what's putting you at risk. It's the risk of predators, it's the fact that you have no money to support your little siblings, it's the fact that maybe, one of the things I learned in Uganda, I don't think I have this picture, but one of my favorite my biggest lesson of my life was working with these kids, 11 to 14 years old. And we taught them about how AIDS was prevented, how it was transmitted, how they could protect themselves, etc. And when we got to asking them, okay, what are your risk factors? And this was like an intensive educational course for peer educators. It was 2 weeks, they'd all be together with their teachers and everything. We'd ask them, what's your main risk factor? And these kids said, poverty. And for me, I could have said, oh, they're ignorant. They don't get what I just was trying to teach them. But instead, I said, oh, they're teaching me something. And particularly for girls, what they said is, look, I know I'm an orphan already. And if I don't ever learn to read and write, I will definitely get AIDS. I mean, in the community I lived in, 35% of people were HIV infected. Okay, so most of these kids knew people, had lost people, sisters, brothers, aunts, uncles, parents. So they knew that if they, as an orphan, didn't know how to read and write, what is the future for them? To be a servant, to be a domestic servant. In which case they have absolutely no control, right? They'll be raped, they'll be abused, they'll be violated. But if there's some nice man in the community who will pay for them to go to school, and maybe they'll learn to read and write, maybe they can make something of themselves, and if that man wants to have a sexual relationship, it's not a bad choice, right? I mean, it's not a choice you'd want anyone to have to make. But in comparison, these girls were actually choosing probably a safer option. But it's sick. It's sick. It's sick because school isn't free, because all of these things we talked about at the beginning. What we need to do is change the social context. You know, that school becomes a basic right, that, you know, because school fees have been a huge issue for young girls and boys, particularly girls, in poor countries that put them at risk for HIV. And so they're trying to better themselves, you know what I mean? So, you know, we wrote a paper and it got published in the British Medical Journal saying, you know, prevention isn't sufficient. Now, look at when we wrote this in 2003. In 2003, there was still almost no movement, just starting, to provide treatment for HIV. Remember, I said the treatment came about in '95. So you have 8 years of essentially 3 to 6 million people dying per year of a treatable disease. You know, so we published that. We published something that was oxymoronically called the Harvard Consensus Statement, because you can't have a consensus at Harvard. It's actually illegal. And we did that for one reason only, to show this graph, which was showing that little red line was the massive, which seemed to us massive change in death rate. But when you put it on the scale of what was happening for the untreated epidemic in sub-Saharan Africa, it just like vanishes in significance. So we really said, look, we as Harvard faculty members would like to see treatment become part of the debate. And we published it in a stupid journal that nobody reads called Topics in HIV Medicine, and it went viral. Before things could even go viral, it went viral. Who made it viral? Who do you think made it viral? It was before YouTube, believe it or not. It wasn't academics, I'll give you a hint.
Patients.
Huh? Patience. Activism. And to me, this is what has really made a big difference between HIV and other problems we face. And I would like us all to learn how, as scholars in this work, we can harness that activism toward other things. Because it was the patients, people living with AIDS who were activists in the US, in Europe, and in the South, in Uganda, in South Africa, in Zambia, who really forced this stuff down the throats of the politicians and policymakers. So who is your audience? So we're dealing with these things like it's too hard. I mean, the head of USAID, who you guys live in Boston, so you'll know, is the same man that brought us the Big Dig. You're a little too young. Okay. Andrew Nancio said this. This is why we can't do AIDS treatment. Many people in Africa, and there are some Africans here, right, have never seen a clock or a watch in their entire lives. And if you say 1 o'clock in the afternoon, they don't know what you're talking about. 2000 in the New York Times. 2000, the year 2000. What is this? Oh, it's a watch! Oh my God! right? Crazy. So what do you do to combat that? I mean, you could protest, and that certainly happened. But the other thing you could do if you're a geek, is you can start writing articles and papers. And so we wrote our first scholarly article about HIV treatment in rural Haiti with just 60 patients. And we said we had no labs, we had no viral load, we had no CD4, we had nothing. And we said, but the patients didn't die, and they went back to their families. And I was kind of excited. This was like the first paper I ever wrote, and this was the most universally hated paper. Although it's, by the way, of the things I've written, is by far the most cited. But public health people, medical people said, this is ridiculous. In fact, they invited us to write a second article for the WHO Bulletin. They have a feature called the Roundtable, which is like morbidity and mortality rounds. So you write this thing and people just make fun of you. So we're like, okay, we can do that. And in making fun of us, they said, this is silly, this is gold-plated, this is the... What was the deal? By the way, activists were jumping up and down. Yeah. Jim.
Maybe they didn't want to believe it, that this is actually happening.
Why wouldn't they want? I mean, it's like kind of like the see no evil. Like you're right, but
make it more complex. Really.
It makes it. It's like MDR-TV. It must be the patient's fault. At least MDR-TV, someone could be blamed. But for this, so how could they not believe it? What's the critique you get in medicine or in science if people don't believe it? Not a good study, not controlled, not randomized. You need more data. Right? So that was there. What else? Why else?
Like you said, just 60 patients.
You're too small. And by the way, at this time, in 2001, paper after paper after paper, you can look, hundreds of papers were being published every year about the natural history of untreated HIV infection in Africa. Oh! In Nigeria, people die of AIDS too. Oh, in South Africa, people die of AIDS too. Oh, in Zambia, look at this, people die. I mean, this, and nobody's batted an eye. Right? And we publish this, and we're kind of totally beaten up by, what else? So it's like too small, not scientific. It wasn't even published in like a research thing. It was published in Viewpoint. This is our Viewpoint in the Lancet. So why else were people so critical? Yeah?
If that was not scalable?
Not scalable, not sustainable. You're doing something. So what do you say to that? Is that legitimate? You can say it's legitimate. I mean, my politics are obvious, and my son's name is Che. So, anything you say is going to be slightly to the right of me. So don't worry, and I'm not critical of that. So what do you say about that? Is it scalable? Is it sustainable? What does sustainable mean in this context? You guys have heard this, yeah. Well, it's funny. That's what it should mean. That's what I would like it to mean. But really, in a public health context, to date, what sustainable means is that a country can sustain it on their own resources. So what is the health budget of most heavily indebted, very poor countries per annum, per capita? $5. Okay, $5 per person per year. So how much does even TB treatment cost? You have an idea? Good to know these things. $12. Infant vaccination, anybody? $2.40. So, you quickly run out of that health budget. So anything else will break the budget. And in some countries like Haiti, the annual health budget was $1.75 per person per year. So the government couldn't even sustain infant vaccination because the government buys the vaccination for $2.40, the whole package from UNICEF. But they couldn't do it. So even the very most basic, so we have constrained poor countries to that as the optimization function. Right? This is your health spending. Everything that's sustainable you do within your rubric of what you have. The life expectancy in these countries is 39, right? And now you have AIDS, and you have tuberculosis, and you have all these things, and many of them are treatable, but somehow we've got to change the optimization function. You know, when I was in high school physics, this is my geeky reference, what I learned is the only state of the universe that's sustainable without inputting energy is what? High school physics, anyone? Entropy. Chaos. That's what we've got. We've got chaos. And you have to input energy, which is human resources, which is capital. If you want to change the chaotic nature of healthcare for the poor, you're going to have to input energy, technology, you know, medicines, commodities, electricity, right? Back to the electricity slide. So this was totally about the sustainability argument. So while people didn't quote unquote believe it, of course they believed it. Of course they knew if you treat a Haitian with HIV, they will do just as well as an American. In fact, better, because they know they only have one shot, and they're really, really compliant. You know, Americans, 50% of Americans after 1 year of therapy are already resistant to their drugs because they don't take them. That has not been the case in the developing world. And just to go back to our Sanjay Basu, so Sanjay was like, scrounging around, because at this time the treatment was $10,000 per patient per year. So Sanjay's running around Cambridge collecting unexpired antiretrovirals and giving them to us to treat patients. And you know where Sanjay's name comes up about 6 months into this? The Wall Street Journal. This was an MIT undergrad. A little dude named Sanjay Basu is in the front page above the fold in the Wall Street Journal for what? It wasn't a positive article. Violating international intellectual property rules. And by the way, Haiti had no patents. Haiti has no patents. No patent law in Haiti. So, why would the Wall Street, this is 60 patients, this is a kid in Cambridge running around getting unexpired drugs. Why would the Wall Street Journal put an article about him above the fold? I'm old into the above and below the fold, which is kind of dated, right? Because we don't have the fold anymore. I got my iPad. I like that. So what do you think the Wall Street Journal was thinking? Are they paying attention to this? I mean, why would... The Wall Street Journal's, you know, pretty respectable, if you like that sort of thing. What do you think they were thinking? Why pick on Sanjay?
Well, they like to write about the profits of drug companies.
Right.
So Sanjay was undercutting them.
Right,
But
so little. Yeah. But they saw it. They're smart people. These capitalists are very smart. I know that. They're tricky and they're smart, and they see that this is a terrible example. This is a terrible example. You know? And so it just tells you how entrenched these systems are. That you need this really, you know, to attack them, you really need to have a complex system of attacks. So when we, you know, other things we dealt with, people said, oh my gosh, you know, like the patients won't be able to take their meds, they have no watches, they have no, you know, we had one picture with all our patients with watches on, very funny. But we also had community health workers, back to your concept with smallpox, because one of the positive things we all learned in public health is by harnessing the enthusiasm of community, you could really get out to the most difficult to treat patients, but we also paid community health workers, which was highly controversial and remains so to this day, because the idea is people should volunteer to do that. What do you think about that?
You were talking about community health workers, and you know, a lot of, for example, in Haiti, the strategy of community outreach is not even including the national health
Yeah,
policy.
what's up with that?
And it has been, we had a lot of results, because I'm from Haiti, we had a lot of results, Partners in Health and a lot of other. So it's all.
So why do you think that? Why do you think that?
Because I think it's still, they see public health as institutions and not really public health has to be also a link for the community and the health institution. So
And they're
always
begging
a
it.
gap.
They're begging
Yeah.
us for it now. I'll tell you,
Yeah.
Dr. Larson, the Minister of Health, is saying, help us figure out how to do this on the national level.
We have to, because it has to be legitimate.
Yeah. What about pay? What about compensation of these community health workers? Because that's the standard public health approach is volunteers.
How much time does it take?
Well, for our guys, it's a full-time job. I mean, you know, Haiti is rural Haiti is extremely sparsely populated, unlike Rwanda, and so you really are hiking for 6-7 hours a day.
And then you have to think about sustainability, recruitment, and retention of these healthcare workers, and paying them goes a long way in doing it.
Right, so there's plenty of data that shows the attrition rate for volunteer health workers is profound, very quick. Yeah.
There's a status associated with Black in healthcare,
Yep.
and there's strong historical beliefs about what is adequate training,
Mhm.
who can be trusted to make
Yeah.
a decision. And
Yeah.
I think anytime you start talking about task shifting
Yeah.
from an expert to the community,
Yeah.
you run into unestablished.
Yeah, so there is definitely this sort of protection of trade. You know, nurses are worried if community health workers give Depo-Provera, then they'll be out of a job, that kind of thing. So we've got the attrition thing. So we really felt like paying people. It's a full-time job in Haiti. Not true in all of our sites. In Haiti and Lesotho, definitely full-time. In Malawi, definitely full-time job. Other thoughts? I mean, I think one of the pieces of what you said also is by providing work as a health worker in the community, you can elevate the person's status too. So the large majority of our community health workers in most countries, particularly in Southern Africa, in Lesotho and in Malawi, are women. So in terms of attacking gender disparity and providing jobs for women, like it's part of our social strategy actually, to have, you know, and we have a very high preference for people who are living themselves with HIV. So, you know, we're trying to do a progressively structured recruitment and retention for the most vulnerable is also a job creation strategy. And today, like, we have 5,500 patients working for Zombie La Santé, and more than 3,000 of them are community health workers. So these people that's the only job they've ever had, often, in the formal economy. You know, the main critique of it is too expensive, not sustainable. That's the main critique. That governments with a healthcare budget of $1.75 per person per annum, they can't afford that. For us, you know, HIV has given us a window to say, well, you know, we're doing all this, you know, the healthcare worker doesn't add that much to this, but we'll talk a little more about that. So we've written about the healthcare workers, again, to say, not only is the payment worth it, and in this article we put some charts of, if you save, for every year you save a patient from going to second-line drugs, which are tenfold more expensive, because today the price of first-line antiretroviral drugs is less than $90 per person per year. And it was $10,000 in the Sanjay Basu era, right? So, yes, so $10,000 to $90. Right? To see that drop of 100-fold, more than 100-fold price in your lifetime makes you feel like you can do anything. Makes you very optimistic, I would say. Cocky might be another descriptor of partners in that sometimes. But so, you know, we wrote this to say it's feasible. Again, it's feasible. This is how we do it. This is the benefits we think it makes. This is how you can end up saving the government of Haiti money because they've already committed to now treating HIV. See, as we were able to push the envelope on HIV, even more than tuberculosis, the government had plans to treat everyone and treat everyone for free. And in places like Nigeria, in places like Mozambique, in places like Malawi, you can get HIV medicines for free anywhere. Crazy. Like, think about that. I mean, that is just a massive sea change. And we also documented what this massive price drop did for our ability to provide universal access. So this is, you know, the $10,000, and in a span of less than 4 years, we were at $150 per capita, and all of that was advocacy. It was getting the drugs on the WHO essential drug list. It was AIDS activists, you know, shutting down conferences in South Africa, you know, following around Al Gore and chucking blood on him, and I mean, you know, I love these guys. You know, and they have the good sense often to not be the front man. You know, they'll put me up. Well, she cleans up good. Let's put her there, and then they're back and, you know, throwing blood and stuff. I never had to throw any blood. kind of disappointingly, I would say. So we also published this showing that if you have large-scale procurement, if you demonstrate demand, if you go with this sort of rights-based argument, you will see a price drop. This is what happened in TB, and this is what happened in HIV. And we're hoping it will happen other places. And then the other argument we said, because as this started rolling out, we're back in the same rubric where everyone's saying, well, the governments can't afford it, so you have to put some cost recovery. You have to get people to pay something, otherwise they won't appreciate it. And what we saw everywhere is anywhere that people had to pay, they didn't stay on the drugs. They had to pay for tests, if they had to pay for transport, so that the whole idea, we said, right now we are rationing care worldwide by ability to pay. How do you make the delivery of HIV services a right? And we showed that you do that through the public sector. So even though Partners in Health started with this private, beautiful private clinic in the middle of nowhere, we now facilitate, have revitalized, operate 60 public facilities around the world with governments. Because we said the right to healthcare demands on the government being able to deliver. And we're going to help to capacitate the government. Our view is a rights-based approach takes two pieces. One is the engagement of the community. And that's kind of bread and butter human rights work. Everyone believes that. That's really good. That's what's going on in Egypt now, and we're happy to see it. But the other one is you have to enable the government to deliver on rights. Because if the government can't deliver, people can chant and shout up and down till they're blue in the face, nothing's going to happen. So we made the concrete decision when AIDS money started coming, and even before that in Peru with TB, that the real effect of our program was not as an NGO. It was as a lever to ensconce that into a government program. So in Peru, for example, we started out showing feasibility with 75 patients. Like in Haiti, we showed feasibility with 60 patients. But today in Peru, more than 10,000 people have been treated for drug-resistant TB, all on the government's program. So we worked with the government to train them and to work on it and protocols, etc. And that's how we develop scale. But that scale depends on governments being able to get more money into health. And that's usually the international and financial institutions like the World Bank, the IMF, the US government, etc. So, fighting all these fights simultaneously is very complex. But what we showed is, let's take this HIV money and instead of developing the vertical programs, like the polio thing, we're going to say, you can't find HIV unless you have a functioning clinic. You can't treat HIV unless you have a functioning clinic. A lot of the clinics that we worked in, I remember our visit in 2003 to Buchan, two-room clinic, closed most of the time. The doctor that worked for us was selling radios in the market because he hadn't been paid for 9 months, right? And then everyone's like, well, no one has faith in the public sector. Who would have faith in that? It's that the world doesn't have faith in the ability of the delivery of healthcare as a basic right. So we said, we're going to use HIV money to make this clinic work. And then, by the way, we'll provide HIV testing and treatment, but that, in fact, it's the strengthening of the health system that's key to providing real scale-up for HIV. And we showed that, you integrate HIV in primary care through provider-initiated testing, you integrate HIV through tuberculosis, you integrate HIV in women's health and sexually transmitted disease and child health, and that sort of gives you the whole gamut. And so we justified huge investments of global fund money and even PEPFAR money, which was trickier, into health system strengthening to meet our HIV targets. And what we saw was really remarkable. This was the clinic I was talking about. Hamish and I visiting in 2003, and this is what the clinic looked like, right? And this is 3 months later. And now, I didn't randomize for the rainbow-colored awning, so maybe it's just that. But that we have a confounder, is rainbow, nations like rainbows, l'arc-en-ciel, I don't know. But we did 4 things with HIV money in this public facility, 4 things. 1, we put in a package of essential drugs, not only HIV drugs. So penicillin, paracetamol, anti-worming medicines. And in fact, that investment was pretty cheap. The second thing we did was get rid of or consolidate the user fees. because any fee for service, for utilization, is a barrier to poor people, and that's been documented all over the world. Okay, and I say consolidated because often when you're working in a public clinic, you can't get rid of the fees because the government has made a deal with the World Bank that they have to have cost recovery as part of their health strategy. So what we try to do is, I'd love to get rid of that. In Malawi, they have no user fees. It's the only country we're working with no user fees. But in every other country, we try to sort of help the clinics have large exemptions. So, you know, HIV patients, TB patients, kids under 5, pregnant women, anyone with 1 teeth, you know, people with maybe fungal nail infections. I mean, we try to exempt about everybody. Because what these user fees bring in is so little. It doesn't even matter. It's an ideology. It's not really a system that works anyway. So consolidating user fees, essential drugs, paying the staff to do their work, helping the government to pay the staff, and then the fourth thing is the community health workers. And within doing nothing physically to the clinic, now this is now a beautiful hospital, Mukherjee actually, but with doing nothing to the infrastructure, just providing services drove up utilization, and then we could do thousands of HIV tests and get people on treatment. And so here's my gratuitous picture of Al Gore. Come on, you're supposed to laugh. Don't you think? Isn't it good? You got Keith Richards, you got Al Gore. Did he invent the internet? I mean, you guys should know, you're at MIT. What do you think, Hamish? Did he invent the internet? No. Okay, so you know, how do we use technology to sort of harness technology to help us with this system? And we made a very strong early commitment that Hamish was, you know, really the lead on, to say you cannot deliver care of this complexity without an electronic medical record system. And Hamish talked to me until I was blue in the face about open MRS, and I have to tell you, I didn't get it until maybe 3 years ago. I was like, wow, that's brilliant, you know. But we did it for HIV, for TB. We're doing it more and more for other things. Why? Well, one is public health had never taken on chronic diseases. And once you take on a chronic disease, you need a longitudinal record. And anyone who's ever been in a clinic in a poor country knows there ain't no record keeping. Right? I mean, there's files like this, and some poor person who's paying like $1 a day who's going, I mean, can't even read, and it's like a nightmare, right? Everybody's got 6. This is true. Is everybody with? Okay. So you know, we said this has to be ensconced in that. And we're fighting for not only the electronic medical system, but the whole technology framework to put that in, which is satellite internet. What do you think satellite internet does for a clinic? Take out the record system. Decision support. So definitely you can help. You can do telemedicine. You can do decision support. I get, even today, even though, you know, no one really needs me anymore, I still get, you know, what do you think about this patient kind of thing, you know, casual or formal decision support. What else? What do you use the internet for? What?
It keeps the employees abreast of the latest practice.
Absolutely. So up to date, looking at Medline, searching articles. You know, our physicians and nurses want to be good. You know, they want to participate in the global debate about HIV or TB or malaria. So that, you know, can make them not feel so isolated. In every country in the world, doctors and nurses do not want to work in the middle of nowhere. And that's one of the reasons. Why else? What else would it be helpful for? Yeah?
So archival of the EMR.
Yeah, so, you know, having the history of what we've done, very important. Tracking the patients, yeah. And really, yeah, go ahead.
News and entertainment.
Yes! Quality of life for the staff! Like, doesn't the internet kind of help your quality of life? I mean, the fact is these are people in the middle of nowhere. Now, you know, we have some problems occasionally with downloading of porn, but okay, it's all right. As long as they do it safely. But no, seriously, for people to keep in touch with their families by Skype, for people to have friends on Facebook in other countries, this is also a really important way to make people's quality of life in a poor, isolated region reasonable. And we think that's also a valid thing. And then the last thing that was quite a surprise to us was how much it helped maternal mortality issues. When we first put up our first listserv, the Alliance, that's gone down several times because of strangeness, the number one call for help was obstructed labor, hemorrhage, right? We don't have cesarean section in every site, but we have some places you can do cesarean section. And we could rapidly deploy ambulances and get women to hospitals. So the emergency, you think about, we call 911, we take it for granted, but there is no emergency medical response. And that was very much facilitated. It's critical as you're developing these new health centers to be able to prevent death, right? Because you want people to have faith in what you're doing. And you see these kids that need blood transfusions because they have malaria. You see, women who are dying, etc. So, for us, this was something about medical records, but it was also something about quality of life. It was something about developing a system that could provide emergency care. So I'm actually just going to talk for the last 5 minutes about, so what is our plan for scale? Well, in 2005, because of the work in Haiti, we were invited by the government of Rwanda to help them develop a rural health plan, not around HIV, although HIV was part of it, but really how do you harness the community and the public sector? And what the government really liked is they said, oh, this is an NGO that's not setting up a separate system. They're actually helping us to do what we're supposed to be doing, like what our constitutional mandate is. And so we went through the same model. Meet with the community, see what it is the community needs. And these were often really pretty similar, but still the exercise is very important. In fact, the guy standing up in the gray shirt is our head of HIV and TB for our work in Haiti. And he was one of our continues to be one of our chief consultants in Rwanda. So a lot of our Haitian staff who had developed this expertise really have helped a lot in Rwanda and other places. Revitalizing the hospital, saying, this system is broken. Like, you can't attract people to care if it's not dignified. Working with the public sector, and then sort of how you engage community health workers. And I'm not going to talk about all this stuff, but I just want to say something about child malnutrition before I start, because I'm at heart a pediatrician. So, I think for each of these stages, we've sort of seen a problem that is insolvable given the resources that are available. We've tried to document how you could deliver those resources and how much it would cost, and then have a strategy to mobilize these resources. So one of the things we're very involved in now is child malnutrition. And 24,000 kids die every day of malnutrition-related preventable diseases. So 60% of them are related to malnutrition. What do they die of? They die of diarrhea, they die of colds, respiratory infections, they die of malaria. All of these things are, one, preventable, and two, would not kill them if they were well-nourished. But do you know what the public health strategy is for kids, to deal with kids who have malnutrition? The sort of standard public health strategy for kids under 5 is something called GOBI. Growth monitoring, oral rehydration if they have diarrhea, promotion of exclusive breastfeeding until age 6 months, until 2 years of life, and immunizations. And that's the package. But here's the problem. When you're doing growth monitoring, so this is like a standard growth chart. Standard. Everybody's seen this. Chemin Lasante is Haiti, but it's in whatever language, Yoruba, it's in every language. UNICEF handing out like candy. This is the intervention, right? So you weigh the kid in that little gaffing hook, right? You put him in that little blue thing, and then you put him on the chart. Now, by the way, this yellow goes to 0. Like, I think that's not compatible with life. Last I checked. But you put them on this chart. If they're in the red, they're okay. If they're in the orange, they're low weight for age and you have to do something. And if they're yellow, they're severely low weight for age. So what do you do when you find out the kid is in the orange or the yellow? What do you think you do? Growth monitoring, oral rehydration, breastfeeding, immunization. So you've monitored their growth. Check. So what do you do when you find out that they're in the orange or the yellow?
what we should do, or
What do you,
actually,
what do they, traditionally, what do we do? No,
Why
it's
should
not feed them. This is the crazy thing.
they just keep the records.
Keep the records, which as we know are sitting over here going, piling up. And what else? What else might you do? Ladies? Any mothers besides me? Ellen? You might tell them to breastfeed. They can breastfeed more. They might do that because that's in your go-be framework. Breastfeeding, by the way, is not so easy. I would just like to point that out. Especially if you're dehydrated, which most women are in poor countries. They don't make a lot of breastfeeding. The mother. Educate the mother. So you go with this chart. This is really what you do. Come on, you guys have done this, right? It's a chart. It has 4 food groups on it. So you have the orange or yellow baby, and you go, okay, here's your chart. This is green vegetables. These are good. This chicken leg or egg, that's protein. Very important. Your kid is not getting enough of that. This grain, right? This is fat, dairy. Okay, Mom? Can you do that? Because your kid is really... Do you see that chart? Is that helping you? Why not?
It's not very efficient because you don't have access to
You don't have access to those foods. Like mothers know that the kids need to eat. I mean, I have a skinny kid. Right? He's not so skinny anymore. I mean, there is nothing that makes you feel worse as a mother than having a skinny kid. And the poorer you are, the more true that is. Right? Because your whole success as a mother is about feeding your kid. Like they don't care about anything else, you gotta feed them. So the idea that that is the strategy, well, we said, so 2 problems with that. One is you just don't have access. Here's the other secret problem. And this is where we need your help. So I was doing this chart one day, and I said to one of my Haitian colleagues, he's a big tall guy, a pediatrician. I said, this kid is so tiny. He says, no, he's in the red. I said, that's weird. And for the first time ever, I opened my Harriet Lane handbook, which is an American pediatric handbook, and I put the kid on the growth chart, and he was in the less than 5 percentile. And so I superimposed these. And that's why all these kids are dying. If any kid in the US is below the 5 percentile, they get admitted to the hospital. They would get admitted under child protection to the hospital. Okay? This is the majority of children. So one of the things we're really fighting for is trying to document that this is just not compatible with survival. You know, this is resulting in stunting, in cognitive delay, in death. And, you know, the world doesn't want to hear this. This is kind of going back to the, we're not going to see this, we're not going to hear it, because what it says is places like Haiti, 80% of the kids are stunted. You know, and this tall pediatrician said, well, you know, Haitians are smaller. I said, no. He said, well, not my kind of Haitian, not middle-class Haitians, right? So, you know, I'll stop there, but saying, you know, we have, you know, and so one of the things we've done with this is really move toward actual feeding with ready-to-use therapeutic food, which is nutritionally fortified peanut butter, that we can make locally, that we can source locally, that we can pay local farmers to produce and make, and we're going to even put a big factory for it, and, you know, treat malnutrition as a disease, put that ready-to-use therapeutic food on an essential drug list, because those kids under 5, if you don't get them up to their right height and weight, by the time they're 2, you have lost a big chunk of their potential.
Thank you very much, Joia. I always enjoy listening to Joia. And one of the key things here was to really get you thinking, and also in this is a class where we really want people to think about problems out of the box, and to really to question the way that healthcare is being provided, question the structures we have at the moment, and how can we use new approaches, new technology to address those. And I think there are many things that Joia actually has balanced out here, which we will talk about more. But one just sort of caught me was this question about the use of satellite internet. When we went into places like Boucon-Carré and Cage and all the other sites in the central plateau region of Haiti in the early part of the last decade, these were places that had absolutely no communication.
No cell phones.
No cell phones, no landlines. You might get radio from the capital, and that was basically it. And so the question about what changed in the way you can provide care and the way a healthcare organization is working with the ability to actually communicate is absolutely critical. And it's only now that cell phone systems have started to really rampage across the developing world in really amazing ways that people are starting to question, what is that doing to change the nature of what we can do and how we think about healthcare and how we run organizations and what we can do with drug supply and what we can do to get critical information to the places it needs so that patients don't fall through the gaps. Particularly, for example, pregnant women who may need a cesarean section or the instructed labor. So these are the kind of questions that we want you to think about and to sort of really just consider how differently we could provide care and also what other technologies might be available to help with that process.